Hello, I'm Ibrahim Imam, and welcome to another episode of the Neurology Lounge podcast. In this episode, I will continue the exploration of ataxia, and I'm joined by Professor Susan Perlman, author of the book titled Evaluation and Management of Ataxic Disorders, an Overview for Physicians. This was published by the National Ataxia Foundation in 2016. Susan Perlman thought it was old, but we both agree there is probably nothing better published since then on ataxia for physicians, and probably as good for patients as well. Susan Perlman is clinical professor of neurology at the David Geffen School of Medicine at UCLA. She is certified with the American Board of Psychiatry and Neurology, and she had her medical education, fellowship, residency, and internship all at UCLA. Susan has been the director of the Neurogenetics Clinical Trials Program at UCLA since 2007, director of the HDSA Huntington's Disease Center of Excellence at UCLA since 2005, member Medical and Research Advisory Board of the National Ataxia Foundation since 1993, director, Ataxia Center, Department of Neurology at UCLA School of Medicine since 1986, and medical advisor of the Huntington's Disease Foundation of America, the Greater Los Angeles chapter, since 1983. Very busy, and you're still holding all these titles. Quite impressive. Susan has refereed 132 journal articles, 20 book chapters, and 15 reviews. Susan Perlman, thank you very much for joining me on the Neurology Lounge podcast today. I'm very grateful that you honored my invitation.
Thank you for inviting me.
The first question I usually ask is why people write the books they write. What was the inspiration to write this particular book on ataxia?
Well, I've been involved in seeing patients with inherited ataxias, acquired ataxias for a number of years. It's over 30 years now. And at the time I worked with the National Ataxia Foundation to write this small book, there was nothing in an organized fashion to enable a non-expert to find their way through the genetic diagnoses, the acquired diagnoses. And I thought something compact, easy to read, would help, people who weren't ataxia experts to find their way with a patient. And I'd heard from many patients that, they would see a physician, a neurologist, who would say, I know what you have ataxia, but there's nothing we can do. So I thought this would help the general neurologist, especially, to provide a little more to the patients and families.
Okay. And how did you go about writing it? Did you just kind of bring it off head from experience, or
There were some online resources and publications that you could find on PubMed, for instance. In my professional lifetime up to 2016, when I put this booklet together, there were over 30,000 publications addressing ataxia from all aspects. In the last 10 years since the book came out, there's another 20,000 articles. So it is a growing field in a very positive direction. And one sits down, one looks at references, you look at reviews, you look at tables of people who have studied immune ataxia, etc., and you try to organize it. And I must admit, I've always been an organized person since my youth. So it was a work of love, really.
Okay, well, it showed. It was easy to go through for a general neurologist. But for the lay person, I'm hoping some of my audience are lay persons. What is ataxia? How would you describe it?
Ataxia is a symptom. So you cited all my titles, but it's easy to accumulate titles when you're in a niche area. Not too many people are involved in ataxia, either in research or diagnostic specialty, but ataxia as a symptom is imbalance, usually presenting with problems with gait, problems with standing, increased falling. It then can also involve hand-fine coordination, may involve speech or vision as well. It's the control of our motor movement that has gone awry. We have many pathways in the brain and nervous system to control motor movement. We have the signal to lift your arm, kick your leg. You have the on-off button, as it were, in the basal ganglia. And then you have the overriding cerebellum, which coordinates these activities to make sure that the hand goes where it's supposed to go, the foot goes where it's supposed to go.
Now, I note you classified ataxia as cerebellar, vestibular, and proprioceptive. But from your recent answer just now, it looks like these are all coordinated, they work together. How do you tease out the cerebellar from the vestibular and proprioceptive?
So the cerebellum is the grand central station of all this incoming information. What we see, what our inner ear tells us, and what our sensory systems, the proprioception, tells us about where we are in space so that a motor signal can be performed accurately without shakiness and getting to the target. So the cerebellum itself, pure cerebellar symptomatology, is usually seen as difficulty with standing and walking, very general. The way you tease it out in an exam is you have the person stand, they stand with their feet together, they walk a straight line as if they're on a tightrope. The average person, until the age of 80 can do these activities fairly confidently without wavering, without veering, or bumping into things. If you suspect there's a proprioceptive contribution to the upright stability, have them stand with their feet together and eyes closed. You take away visual reinforcement, you rely on your feet knowing where they are. If there's a sensory problem, the cerebellum does not get the signal it needs, and your balance will be off. Typically, you'll fall over with your eyes closed. Similarly, with the inner ear, if inner ear signals are, not coming in correctly, you'll often have symptoms of like you're on a boat or spinning, which can then contribute to the imbalance that you're attempting to identify. The visual problems, if you have double vision or a visual difficulty from another thing, altered vision can also impair balance.
I can see why it's just a symptom. It doesn't give you a diagnosis. The other thing I kind of want to tease out, you talked about the 7 basic ataxia phenotypes. I suppose that's different from this classification into cerebellar, proprioceptive, and what are these phenotypes and what do they tell us about what's driving the ataxia?
So the basic ones, general description, adult ataxias, childhood ataxias. Within that are genetic and acquired, so that you'll have adult onset inherited ataxias, you'll have childhood onset inherited ataxias. You'll also have non-genetic ataxias, so that acquired ataxias from poisons, toxins, or immune system problems, as well as degenerative ataxias. Just like Parkinson's disease is a degenerative disorder of the older adult, Alzheimer's disease, similarly, with essentially no genetic factors, there are degenerative cerebellar disorders that present, in adulthood, usually after the age of 45 or 50, constantly looking for a genetic trigger, constantly looking for environmental triggers, but as yet unidentified. So, if we look at, what these look like, the adult onset ataxias basically look all the same for the first few years until they begin to show other features or positive genetic testing, predominantly cerebellar, problems with balance, problems with hand coordination, tremor, slurred speech, visual changes. The childhood onset ataxias fall into 2 categories. One is the ones that look like Friedreich's ataxia, which is spinal long tract involvement initially, and the others that look like cerebellar involvement. So these are usually sorted out by imaging. If you do a brain MRI of a child with ataxia, you'll either see atrophy or changes in the cerebellum or atrophy or changes in the spinal cord. Multiple system atrophy is one of the degenerative changes that we're seeing more commonly now and diagnosing because there are good clinical trials that are running. This is, predominantly non-genetic and includes ataxia, Parkinsonism, autonomic problems, problems maintaining blood pressure, problems maintaining normal heart rhythm, bowel and bladder function can be affected. And these will be clues that will separate it out from the other adult ataxias. So, that's the basic, kind of rundown of, how we classify the ataxias.
And that would be kind of what you have at the back of your mind when you are seeing a patient, kind of right from the beginning. The other thing you mentioned about distinguishing between the genetic and the acquired, you said genetically mediated ataxias have insidious onset and relatively slow symmetrical progression. Is that a helpful clue in picking them out, distinguishing them from the acquired cases?
It is probably the most helpful thing we can get in a history from a patient who says, I've had this balance problem for 15 years. It was relatively mild, but now I'm having more difficulty. That long development is often a clue that there's a genetic factor. But we still have within our adult patient population, probably 20 to 25% who give a story like that. And we strongly feel there must be a genetic factor, but current level of genetic testing hasn't revealed anything yet. In the last couple of years, 2 new genetic tests have come out, one for spinocerebellar ataxia type 27B and one for RFC1 or Canvas. And that has actually cut our undiagnosed adult ataxias in half, taking idiopathic and moving them into a genetic category where, we can predict better and also develop better treatments.
And yeah, that's very helpful. Canvas is a very catchy name, and it's a good one to remember, I suppose.
Yeah, the acquired ataxias typically come on more rapidly and worsen more rapidly. So if you have somebody whose ataxia has worsened over weeks to a few months, you'll look for an acquired cause. An underlying cancer that's making a bad antibody that's attacking the cerebellum, or, a poison or toxin or environmental exposure that may have triggered it, or a viral infection, relatively common in children with sudden onset ataxic symptoms.
Okay, that's very helpful. One of the things that we're taught as medical students and training is the family history and the link with genetic disorders. But quite a lot of statements you made kind of show there's often a discordance between family history and genetic disorders. What are the difficulties? Why does that happen? And what should a physician do to kind of reduce that risk of falling into misdiagnosis because of the presence or absence of a family history?
So in a European study, they found, doing genetic screening in everybody with a cerebellar disorder, 5% did not have a family history. So it's important when you're seeing somebody with no family history to, number one, think could be genetic. Why would there be no family history? Sometimes the family history is hidden. You just don't know that there are relatives who had this. It was felt to be, a mysterious disorder, a scary disorder, and wasn't talked about. Sometimes, there's paternity issues, or somebody's adopted and the family history is unavailable. But certain genetic factors that are mutatable, so that the mutation on the genetic side can become bigger from generation to generation, a small mutation in a grandparent may have caused no symptoms at all in their lifetime. When passed on, if the mutation became bigger, all of a sudden it appears as it were out of the blue. So there's a variety of things that genetics experts, will tell you could hide or blur a family history. And sometimes it's just misdiagnosis. I had a family with Machado-Joseph's disease, SCA3, where the grandparent had been diagnosed with alcoholism. The parent had been diagnosed with B12 deficiency. And finally, when the child, or was a young adult, came in with a balance problem, genetic testing had become available. We sent the genetic testing and were able to make the genetic diagnosis. Okay. However, the flip side of that is not everything in a positive family history can be related to the gene. So in another Machado-Joseph's disease family, was working with, well-defined family history, young member of the family comes in, work him up. No other cause was found at the time. Genetic testing was not yet available, but we said, well, this is what's going on in your family. This is probably what you have. He turned out to have multiple sclerosis. Okay. And an additional one in a Friedreich's ataxia family with 6 children, 5 affected, which is unusual for a recessive disease. The youngest one, newly diagnosed, a little different from his older siblings, turned out, with the further workup to have a spinal cord tumor. So you must never assume that everything that goes on in a family tree is going to be genetic. Even somebody with a known genetic factor, if something changes, you have to think they're not immune from other things.
That's Occam's razor out of the window then. Okay. So you have someone in front of you without a family history. I know you talked about the rate of progression and onset. Are there other factors you would consider into saying this person needs a genetic testing? On the assumption you're not testing every person with ataxia for a genetic cause if there's no clear.
Well, what are we not? I run, our ataxia clinic, which is based on, neurogenetic ataxias predominantly. So by the time somebody is referred to me, usually the acquired causes have been ruled out. The vitamin deficiencies, the poisons and toxins, the hidden cancer causing an immune system problem or other autoimmune diseases. And they're sent to me, could this be genetic? So that for most of the patients that I see, I will order genetic testing, even if their phenotype looks unusual. Multiple system atrophy is the unusual adult ataxia. They can present with predominantly ataxic symptoms. Within 2 to 3 years, they will begin to develop the full phenotype of multiple system atrophy. But the first couple of years, they look like anybody with ataxia. So it's appropriate, even in an idiopathic sporadic ataxia that hasn't yet evolved into an identifiable MSA, for instance, to do screening for at least the common genetic ataxias.
And so do you have different levels of panels then as kind of the first go, these are the ones I would test for if they fit into this category, or do you just send them off for the whole?
Well, it's so easy to check one box and get all of the repeat expansion ataxias, which is a specific type of genetic mutation. If that is negative, you then go on to look for exome sequencing or whole exome sequencing or whole genome sequencing. Back when genetic testing for the ataxias first became available, there was like one genetic test for spinocerebeller ataxia type 1. So everybody got that test done. Then, the menu grew. Different companies became involved. And, you would, sometimes be a little selective. But right now, it's reasonable to order a panel, and what I usually do is order the repeat expansions. They tend to be the most common mutation, then going on to whole exome sequencing, looking for point mutations. In children, it's sometimes reversed. point mutations are relatively more common in childhood genetic disorders. The repeat expansions, less common, with the exception of a couple that can present in childhood.
Okay. At the time you wrote the book, I think Fragile X tremor ataxia syndrome was the new kid on the block. You've already told us now that newer kids on the block. What's you described it as an interesting new form of genetic ataxia. What's so unique about Fragile X tremor ataxia syndrome?
It's interesting because it presents in older men where there's a family history in a grandson of Fragile X mental retardation. And that's how it was discovered. In families being studied for Fragile X mental retardation, it began to be noticed that there were grandfathers who had ataxia. Further investigation showed that a smaller mutation in that gene on the X chromosome, which men carry 1X, would cause in these older individuals ataxia, tremor. They can have Parkinsonian features. They can have cognitive problems. So there's some overlap with Parkinson's disease, with other degenerative disorders of the older person. And it was, it opened up a whole new world of, looking for the family history, not prior, but, current family history. How are your grandchildren doing? Or do they have any issues? Women who have two X chromosomes, one of which becomes, invalidated and the other one stays active. So if the mutant X chromosome stays active, then they can also have milder symptoms of the Fragile X tremor ataxia syndrome.
Okay. It has a catchy name as well, just like Canvas. The other genetic one, which you've talked about, is the spinocerebellar ataxias, and you talked about 27B, but the numbers seem to be increasing exponentially. Is there a limit to how many scars there are, and how do you approach which one to test for? Do you just test the whole range?
So when the book was written, there were 40. There are now 51. Some of the newer ones are point mutations that have been found, sometimes just in a couple of families. And then, it found that there's some consistency with the mutation and people who have symptoms. Many times, you do whole exome sequencing in an average person, and you'll find one gene or 6 genes that have a small change that you don't know if it's pathologic or not. They're called variants of unknown significance. So you can track many of these through family trees and other families that may have the same variant. And at some point, the statisticians will tell you that is the causative mutation, and it gets a new number, SCA51 or whatever. So the arrangement now for genetic testing, they began with panels, looking mainly for the repeat expansion mutations, which could be tested as a panel, and then reserving, sequence analysis or whole exome sequencing, looking for point mutations. Most companies now will offer a panel that includes all the repeat expansions, which are the most common mutations, including the spinocerebellar ataxias, as you've mentioned. Friedreich's ataxia is a repeat expansion. SCA27B is a repeat expansion. And Canvas is a repeat expansion. Fragile X is a repeat expansion. So all of those will be on one panel, which will cost a few $1,000s. And then you go to the whole exome sequencing to look for point mutations if your panel of expansions is negative. And there are companies that will do whole exome sequencing for $1,500 and some that will do it for $7,000. So, depending on what your insurance company will cover, at least in the United States, it's a jungle out there regarding what the insurers and payers will pay for. But usually, with the help of our genetic counselors, we can find a way to efficiently get the testing with the least financial burden for the patient.
Okay. And the question that just occurred to me, how much does the phenotype we know clinically match with these genetic mutations? I know SCAR3 is meant to be like this and SCAR2. With more testing and more patients, how closely do the phenotypes match with the genetic diagnosis?
For the dominantly inherited SCAs, spinocerebellar ataxias, in the first couple of years, they all look alike, and you really need genetic testing to differentiate them. SCA2 will develop early slowing of eye movements. So I saw a patient with, a very typical balance problem, mainly standing and walking were affected, but his eye movements were a little slowed. And it was a teaching case, and I predicted this one has spinocerebellar ataxia type 2, and lo and behold, he did. The most variable phenotype is SCA3. It can include the cerebellar features. It can include a peripheral neuropathy. It can include upper motor neuron spasticity, as well as Parkinsonian features. Earlier onset is more spastic dystonic. Later onset can look like Parkinson's disease or an ataxic peripheral neuropathy. So there, in fact, Machado Joseph's, when it was originally described in the Azores, was felt to be three different diseases. The early onset spastic dystonic, the later onset Parkinsonism, until somebody figured out these were all members of the same family. And ultimately the genetic factor and its influence on the nervous system was discovered and explained that. There are certain rarer ataxias. Spinocerebellar ataxia type 10 is associated with epilepsy. Spinocerebellar ataxia type 7 is associated with vision loss and blindness. So there may be some clues in the phenotype. But in the beginning, you must look, really at the whole genetic pattern.
And I can imagine there will be a lot of SCAR3 patients scattered across all the subspecialties, nobody ever thinking that they have. Okay. Before we leave the genetic and go to the acquired, I need to touch a bit on adult onset or adult presentation of Friedreich's ataxia. And I think I've read their reports of those being diagnosed even in their 50s and 60s. When should somebody suspect that somebody has a late onset Friedreich's without any past history, no family history, nothing?
So with the late onset disorders, usually after the age of 40 or 45, you think non-genetic, you think multiple system atrophy, and 20% of late onset predominantly cerebellar syndromes will then evolve into multiple system atrophy, again, non-genetic. There are some of the dominantly inherited disorders that can have later onset. Machado Joseph's is one, spinocerebellar ataxia type 2 is another, SCA6 is another. But, you usually don't think of recessive disorders. So Friedreich's ataxia is a recessive disorder. Most recessive disorders present in childhood. Most of them are a deficiency of an important protein that will present fairly early on. So the typical Friedreich's ataxia case was described over 100 years ago. And it was, noted to be in families. They had upright stability problems, ataxia for standing and walking, posterior column sensory loss, loss of vibration and joint position sense, absent deep tendon reflexes, and upgoing toes. That phenotype was enough to say, named after Dr. Friedreich, this is Friedreich's ataxia. And until we actually had the genetic testing, we could qualify our diagnosis very much by how the person presented. Once the gene test came out, we found 10% or 15% of very typical Friedreich's childhood onset, the phenotype I just described, were gene negative. So there were Friedreich's ataxia mimics in childhood, although Friedreich's ataxia itself was the most common childhood ataxia in late childhood and early adolescence. We began testing some of our older ataxia patients with slowly progressive problems that we figured must be genetic, but we didn't have a lot of genetic tests available in the 1990s. And about 10 to 15% of our diagnosed Friedreich's ataxia patients began to have symptoms after the age of 25. And my oldest patient had onset of symptoms at age 69. And there are others that are reported as well. They had very small mutations. They were making some of the protein that the gene was responsible for, not quite enough to keep their nervous system healthy through the entire lifespan. So, we now, think about Friedreich's ataxia in an older patient with no family history, with features that are suggestive of the phenotype of Friedreich's.
Okay. One has to keep the mind open when approaching a person with ataxia.
It becomes more important to make a genetic diagnosis when treatments are becoming approved for some of the rarer genetic factors. So, back in the day, you could test for it and, you have a positive gene test for spinocerebellar ataxia type 1. And you'd get all excited and the patient say, well, what can you do about it? There's nothing you can do. There's plenty you can do, just nothing to target the gene. But now we actually have clinical drug trials and approved drugs for some of the common ataxias. So making that diagnosis can open up a new treatment pathway for the patient.
Okay. I mean, that reminds me about a question I was going to ask you later, and that was about you wrote that the current treatment of cerebellar ataxia remains primarily a neurorehab challenge. So clearly things are changing then in this regard.
Still, physical therapy, occupational therapy, speech therapy always help. There is not an ataxia patient where it will not help. But now we can build on that and do other things.
Okay, that's a bright future coming around. The other one that kind of doesn't flag up in when I'm seeing patients, mitochondrial disorders. How often do these present with ataxia, and what are the kind of the clues to suspect a
Mitochondrial disorders will target any tissue in the brain or body that requires rapid oxidative metabolism, where it can't operate, anaerobically. Like with muscle, you can do sprints and, not use your mitochondria, generate lactic acid, which then recovers. But for long-term endurance, the beating heart, muscle long-term activity, the cerebellum require, available rapid production based on oxidative metabolism, which mitochondria are involved in. So the mitochondrial disorders more often than not will involve the cerebellum. They'll also involve things outside of the nervous system. So there may be an associated heart problem or skeletal muscle problem. There's a separate genetic testing panel specifically for the mitochondrial genes, because mitochondria have their own little genetic makeup within the organelle. But much of the protein that makes up mitochondrial function is produced in our general DNA array. So technically, Friedreich's ataxia is a mitochondrial disease because the protein that it makes or doesn't make in the case of the disorder is important for mitochondrial functioning.
Okay, of the acquired ones, the one that I find challenging is the immune-mediated ataxias. How do you approach these ones? When do you suspect them, and how do you approach the immune?
So certainly for a patient presenting with an ataxic disorder, with or without peripheral neuropathy or dizziness or some of the things that may go along with it, you work up for vitamin deficiencies, you work up for brain tumors, you work up for all of the more common acquired things, multiple sclerosis. At some point, that workup should include an evaluation of the immune system. Paraneoplastic antibodies that could be signs of a small hidden cancer, other antibodies that could be produced that could target the cerebellum even without a small hidden cancer, because these things can be treated.
Okay. You did say that many of the patients that get to you will have had kind of the usual test for the common acquired things. Which of the acquired ones are likely to slip through and for you to diagnose rather than before they come to you? I know you do MRIs, CTs, EMGs, and things like that.
Yeah, I mean, you're right. People have often had a very major workup. Sometimes it's a non-paraneoplastic antibody that was missed. The GAD antibody, GAD, which is responsible for stiff person syndrome, people don't think that it can also cause ataxia. So they order a panel of antibodies looking for a hidden cancer. It's negative. And then I get to fill in the GAD antibody. And, that does come up periodically and it is amenable to treatment. Some of the other things that get overlooked, a history of alcoholism. Somebody, you ask, do you binge drink? You ask about, truly abnormal alcohol behaviors. But for some individuals, chronic alcohol intake over many years can lead to peripheral neuropathy, can also lead to a cerebellar disorder. So you really have to get a good history of, the person's behavior, work-related exposures. If they're working with poisons and toxins, volatile solvents, that can also take away reserve and leave them open to a cerebellar problem as the brain ages. So sometimes it's a series of things. Yeah, I was an alcoholic when I was younger, but I haven't had a drink in 10 years. But you lost your reserve with your alcohol intake. Yeah, I worked, painting things and I mixed solvents and, or I did huffing. I did, illicit drugs when I was younger, but I don't do that anymore. But you took away reserve. So it's important to look at the reserve we build up or take away relative to brain aging. Everything ages after the age of 80, in the Veterans Administration studies, your brain is not going to be the brain of a 20-year-old. But, you can accelerate aging with, behaviors as we've just discussed and targeted problems to the cerebellum.
Okay. That's very helpful. GAD, I'll keep that on top of my head. And it has to be specific. Is it GAD 65, is it?
That's correct, yes.
Okay. Okay, of all the tests, CT, EMG, most of those are non-invasive, but you mentioned spinal fluid analysis, tissue biopsy. How often do you resort to these invasive tests in assessing ataxia?
These tests can be very helpful if you are suspicious that there's a prion disease, prion protein. You really have to look at spinal fluid, and at least in one recent case that I took care of, a brain biopsy established the diagnosis because the spinal fluid wasn't 100% consistent. So rarely do we resort to brain biopsy these days, but the spinal fluid analysis for infectious diseases, certain autoimmune diseases, and prion protein disease can be diagnostic.
Okay, that's very helpful. Helpful to know. Ataxia is such a big umbrella. Okay, I think the kind of the next stage is you've talked about the treatments coming in. What are the real prospects of disease modification with ataxias?
So for any ataxic disorder where there's a loss of cerebellar neurons, everybody's thinking, can you give me stem cells that will cause my neurons to grow back? And stem cell therapy is being looked at for multiple system atrophy, which is mostly a non-genetic ataxia. It's being looked at for the genetic ataxias. And the primary activity of stem cell infusions is not to replace missing nerve cells, although there's research going on to do that, but to stimulate nerve growth factors to allow your own internal stem cells and neural pathways to grow back. So this is an area of neural restoration. Plus, you can give nerve growth factors, and there's been research, around, doing that as well. But most of the disease-modifying therapies are felt to be most important before you've lost too much brain tissue. So with the genetic disorders, you're looking for a way to block the gain of function toxic effects of certain mutations or to replace missing protein. And in the adult ataxias, where there is a toxic gain of function mechanism, there is research going on to be able to inject into spinal fluid or, by injection intravenously, an agent or a small molecule that will interfere with the genetic production of the toxic protein in the brain. So this is a big area. A number of companies are involved in trials as we speak. For the missing protein, Friedreich's ataxia currently has a research protocol to replace frataxin protein, the same as insulin for a diabetic, frataxin protein for somebody with Friedreich's. So, and those are kind of two, very common examples of where the current research is. So disease-modifying therapies are becoming a reality. Up until 10 years ago, we didn't have the technology to develop this, but now, it is definitely the new focus as opposed to antioxidant vitamins or other things that could protect the nerves for a time, but, could not alter the disease process itself.
Okay, and I was going to touch on the symptomatic treatments, things like coenzyme Q, and are they helpful?
So there are antioxidant vitamins and supplements that as soon as, disorders were discovered affecting the brain with free radical production, everybody began looking at vitamin E, CoQ10 and related things. People they take this stuff. Sometimes they'll be taking a dozen different things. And if people want to try these natural remedies, we say start with one, take it for 3 months, see how you feel. If you start with 2 or 3 at the same time and you get a side effect, you won't know what's causing it. But I think most of the things people will notice is energy levels are better, fatigue is less. They may have more endurance, because of the impact on muscle, but the disease behind the scenes is not really going to be impacted. And then there have been studies done looking at high doses of CoQ10 that, couldn't even finish the study because it was clear it was not going to be helpful for disease progression. But, certainly there's a lot that we don't know about natural, about holistic treatment, about, Far Eastern medicine that, we need to explore further. But, if people want to take a vitamin, I say, start with one, see how it goes for 2 to 3 months, change it up. But symptomatic treatment for the symptoms of ataxia, there are some prescription drugs that are being used off-label. There's only one approved drug that seems to have symptomatic benefit and may slow progression of Friedreich's, and that's omaveloxolone. It's marketed as Skyclarys. And in the work that was done in the studies that led to its approval, it did seem to have symptomatic benefit. It seemed to turn back the clock 2 years in patients regarding their symptoms and then slowed progression by 50%. So instead of ending up in a wheelchair, by the age of 20, potentially these patients could be kept on their feet till the age of 30. And currently there is testing being done in the pediatric age group. Most drug trials will start with adults just because of the risk. But for a pediatric disease, you ultimately want to bring it down to the children to see what you can really do to keep those kids out of a wheelchair. However, there's off-label drugs that are used symptomatically. Amantadine, which is an anti-flu agent that was found to be helpful for Parkinson's. When I was a trainee, we were using it for ataxia because it seemed to help, and it does help tremor. It's available in a liquid formulation. It's safe to use in children, so that many of my child patients with ataxia telangiectasia, I have on amantadine to help control tremor and drooling, and it can help balance as well. It's been used in Friedreich's ataxia also for a number of years. Buspirone, an anti-anxiety agent, had its heyday. There are published studies showing benefit for balance, not showing benefit for balance. I still have a few people who are taking it. The next one that had 2 good European studies is riluzole, approved for Lou Gehrig's disease. It was tried in Europe for a short study to see if it would help symptomatically with ataxia. It seemed to. And then for a longer study to see if it would slow progression in a group of genetic ataxias, and it seemed to do that. So currently, that's probably number 1 in off-label drug use in the United States for ataxia. And it's been recognized by the American Academy of Neurology as being appropriate to use off-label for ataxia. And then the final one is dalfampridine, or 4-aminopyridine, which has been used off-label for years for episodic ataxia and the vertigo-associated ataxias. It was ultimately approved for multiple sclerosis gait disorders because of its impact on myelinated pathways, making them function well, even though the myelin is a little frayed, as it is in MS. So we have found in some patients it can help symptoms of ataxia, especially where there's associated dizziness, again, recognized by the American Academy as being appropriate for off-label use. In the pipeline, though, there are a couple of symptomatic drugs that are wending their way through trials and through the FDA, but have not yet been approved for the adult ataxias.
Okay. So it's not doom and gloom. There's a lot of bright light on the
There's a
horizon.
lot you can do.
Yeah.
And that's one of the main messages I give my patients and my trainees is, there's always something you can do that will improve quality of life.
And what's the impact of rehab in ameliorating the ataxia?
So there's probably three things that it does. First of all, it protects muscles. If you have a balance problem and you're less active, your muscles are going to become innocent bystanders. Second, by rhythmic repetitive exercise, you can enhance the coordinated efforts of the cerebellum. It's like training for any sport. You do it rhythmically, you do it repetitively, and you develop, CNS memory that improves your accuracy, balance, coordination. And then the third thing is that cardiopulmonary exercise can increase nerve growth factors. And there have been animal studies in genetic animal models of these ataxias showing that, the mouse who's allowed to exercise on the exercise wheel has later onset of ataxia and slower progression, while the couch potato mice, have a less good prognosis. So you can actually do something that could be in part disease modifying. You can retrain your nervous system and you can protect your muscles.
Okay, that's not to be sniffed at then. It's kind of key. The other thing you mentioned, our coach, is sharing information and seeking new information together can provide strength and encouragement to the patient and family. Is this psychological support, or does it go far in making a difference to the patient?
Half of what we see in the genetic ataxias is caused by the gene mutation. The other half of what we see with disease onset and disease progression and disease performance is from other factors, including, people who don't exercise because they feel it won't help them. Education is always helpful. You have to seek out depression. If somebody is depressed, they're going to be less active and their performance won't be as good. So I think, a good relationship with a doctor who's dealing with a patient with a chronic progressive incurable neurologic disease of any type is education, guiding them to things that will be symptomatically helpful, and listening to their questions and listening to their stories.
Okay. That's we sometimes become too scientific and forget about these bits of patient engagement. Thank you very much for that. You've talked about a lot of lessons so far, but can you encapsulate the three main ones you would want a reader to take away from the book?
So number one is always think about a genetic factor. Maybe not the first thing, but it should come into your differential diagnosis. Number two, even with a genetic factor in hand, don't forget about other things that could influence or affect the patient. And number three, there's always something you can do.
Okay, I think that should be a lesson every listener of this podcast will take away. What are the major questions or uncertainties in the field of ataxia, the kind of challenging bits?
I think with the growth of the genetic diagnoses that we've been able to make, like I say, we're up from SCA40 to SCA51, we have diagnostic quandaries with patients where you think it should be genetic, but all the genetic tests available are negative. So, I think, the search for new genes is still very active. And it's a national and international effort. by people who work with, the genetics of, whole exome sequencing, whole genome sequencing. I think the other challenge is going to be for the genetic ataxias. We have things that we can treat symptom-wise, but finding the drugs that will be specific for the mechanism to slow or stop progression is a huge challenge. The landscape, of the last 10 to 20 years littered with failed drug trials. So we need to get smarter about the drugs that we're investigating, choose better drugs, choose better ways to run a trial so we can tell if it's working sooner as opposed to later. And this is a huge challenge for clinical trial design. And there are groups in Europe and in North America that are focusing their efforts on more efficient ways to design drug trials. And then, I think the third area is to maintain hope in the patient population. It is so easy when you see your family history, you know what's facing you in 20 years, to become depressed. So engaging patients and families in the research effort, can, help, forestall that hopelessness. And, everything they contribute, moves us closer to a cure. Whether we'll actually have cures, I don't know, but certainly, we can cure hepatitis C now. When it was first discovered, it didn't even have a name. So we know that we're moving forward in productive ways.
Okay, that's very hopeful. I was going to ask you what the immediate and long-term futures hold for the field, but I think you've explored it a lot. Anything you wanted to add to that? Kind of what the future holds?
I think the biggest question from patients is, why does it take so long to develop a drug that will then be approved? I mean, it can take 15 years from the first bright idea until it gets approved. The clinical trial process obviously needs to be made more efficient and shortened. And one of the keys to drug development and running a clinical trial is funding. So that is a constant challenge, for an academic center that has a good idea about a new drug, and even, small industry, groups, as opposed to big pharma, who have a promising agent, but raising the money to bring it into trials is a challenge.
Okay. Winding down now. What other books have you published that you kind of...
I did one other book for the National Ataxia Foundation on nutrition, looking at, proper diet. There's been a lot written about, how to cure your multiple sclerosis with diet and things like that. And the general feeling that to preserve energy and performance for any chronic illness, something like the Mediterranean diet seems to be the best choice. You can change it up a little bit, but that seems to, have most of the things that, will help maintain, good health and good muscle performance and good energy.
Okay.
I haven't written anything else,
But
but I have patients who have written books which are very informative.
okay.
And on the National Ataxia Foundation website, they list on their resources link, many of the books that have been published by, patients with ataxia, patients with Friedreich's ataxia, and their discussions of how they dealt with their diagnosis, really, capture your heart. And, I think are good experiences for other ataxia patients to read, to know that you can be a victor in this field.
Okay, so you've answered my question about which 3 books to recommend. I guess there'll be a whole fleet of books on the website.
There are many, and there are many books just about the science of ataxia, but it's changing so quickly. When you write a book, it's already out of date.
Yes.
So, we rely on the literature and the good informational websites that are out there.
And there's so much information, we need people like you to synthesize it. So perhaps you have an updated edition of this book coming out soon.
I think, we may have gone beyond that. First of all, this one is on a PDF format on the National Ataxia Foundation website, so you don't have to buy a hard copy or a soft copy. But there are good websites. The neuromuscular homepage from Wash University wonderful summary section about the cerebellar ataxias, genetic and acquired, where they're constantly updating it. So if you have somebody with a diagnosis of SCA36, you can go to that website and look and see, what with references, what the literature says. That website has grown tremendously in the last 10 to 15 years.
Okay, and it's replacing bookshelves like mine, I suppose. Okay, what projects or what's the major project you are on at the moment, or you have your finger in many pies?
So right now, I've really turned myself into a clinical trialist. The last, 5 to 10 years, we started with one clinical trial for Friedreich's ataxia. My group is now running 20 trials. Half of them are drug trials, half of them are natural history or biomarker studies, for a variety of the inherited and non-inherited ataxias. So I figured one thing I can do, since diagnosis is so easy now, as it were, is to open doors to research so patients can actually participate in promising studies that may ultimately help them and move the field ahead. So, that's my major focus now. And then training people that will take over our programs. I think every Ataxia Center, is, kind of headed by, the old guard, not that I'm that old. And we want to make sure that the next generation of people interested in movement disorders or the cerebellar ataxias or neurogenetic disorders will be able to step in and continue the forward movement.
Okay. Susan Perlman, thank you very much. I've learned so much and a lot of takeaways for me, even for my clinic and my patients. Thank you very much for participating in this podcast. And to my audience, thank you very much for watching or listening. If you found it enlightening, why not subscribe to my database called Neuro Checklist? And I have a little book called Surfing the Brain. You might want to check that out as well. And to make sure you don't miss the next episode of the podcast, why not subscribe either to the YouTube or Spotify channels? But until then, thank you very much for your audience. And Susan Perlman, thank you very much for joining me today.
Thank you.